So, hello there, my name is Danish. Welcome back to the channel. This is going to be the start of something really interesting, really cool that I've been planning over the last few months. I've spent weeks, months, and a good part of the last year trying to get this thing through. So, this is going to be basically like a preliminary, all encompassing course for anyone who's interested in medicine, be it medical students or nurses or just about anyone who likes to think about things in a clinical manner. So, the name of the course, as you can guess, is Foundations of Clinical Medicine Thinking Like a Physician. This video will be recorded in one sitting, and the thing is, we will basically cut parts of this video and post them separately for easy viewing later on. Just a moment. Okay, now that's better. So, welcome everybody. So, welcome again. We are going to start this entire thing with the first week. There is a prior video on this channel a couple of months ago. Probably, I think it was like 3 months ago from this recording, wherein I discuss about what each week will have in its contents. But we'll start. So, week number 1: the art of philosophy of medicine. The art and philosophy of medicine. So it's really important and I think very sweet to think about medicine not as a hardcore technical and brutal science out there, but to understand that it evolved and it was made out of people's desire to understand science and life and human nature better. Evolution of medical reasoning. So many times when you are in your medical school, you're looking at people sharing things that they have learned, or you're in your classes understanding things that your lecturers or your teachers tell you. You might almost always get into this thinking that everyone out there knew the answers to all the questions which are out there, but that doesn't usually happen. What rather happens is, we as a species have had many situations and many occasions where we collectively believed a certain thing to be true, and then based on new evidence we were like, okay, let's move on to something better, which explains more of our observation, more of the things that we see. I'll try to talk less and try to get through the presentation fastly. So from ancient to modern times, this is how medicine has progressed. Firstly, we had Hippocrates, who came up with the idea of humoral balance and clinical observation. Humoral balance is basically that human body has like a bunch of humors. Humors are liquids, which we will talk about in detail later, and the way that they fit in together is how we have basic human physiology going on. Osler was a scientist which came after, and his name is even used in like some of the conditions, which you could Google it. First few minutes in the video, and the guy tells you to Google it. No, I'm just kidding. But we will get to that. We'll get to that. What he proposed was, let us listen to the patient. Let us listen to what he's saying, because he will tell you the diagnosis. After Osler came the post-Osler era, where there was rise of diagnostics and evidence-based medicine, EBM, which we currently practice. And now we currently live in this era where we have integrated reasoning, wherein we follow bedside logic with biochemical precision and systems thinking. So, the origins. The age of observation, from ancient to classical. Firstly, I'm from India, so I would like to talk a little bit about Ayurveda. It is India's oldest medical system. People came up with it in 1500 to 500 BCE, before Common Era. So, what is Ayurveda? Ayurveda is like this type of a type of a medicine offshoot, which was drawn majorly from Vedas, especially the Atharva Veda. It was systemized by Charaka, Shushruta, and Vagbhata. So here is a manuscript from the olden days. I can't read it because it's in Sanskrit probably, and that old Sanskrit. So It would be difficult. What was the core philosophy? The core philosophy was that diseases arises from imbalance of three dosha. And the three dosha, the three means three, obviously. What are the three doshas? So we have vata, pitta, and kapha. Vata is movement, pitta is metabolism, and kapha is structure. So the basic understanding at the time was health is equilibrium of body, mind, and spirit, right? Your body leads to a healthy mind, and your healthy mind leads to a healthy spirit. Here, prevention played a central role because, obviously at the time it was difficult to treat things with medicines and stuff. The major contribution that Ayurveda has had include the following. You have Sushrata Samhiti, which was the first description of plastic surgery, rhinoplasty, and wound care. This is a copy of that. And here we have palm leaves of the Samhiti, or the Sahotara Tantra from Nepal, which is stored at the Los Angeles County Museum of Art. The text is dated to be between 12th and 13th century, while the art is dated to be between 18th and 19th century. On this side, you can see some tools, shastras and kartikas, which are scissors and forceps mentioned in the Samhiti. Now, the problem was, even with how good it was back in the day, people did all that they could, there were still limitations. The limitations included the following: that there was lack of anatomy. People had no permission or no opportunity to do dissections. There was no study of microbes. There was no understanding of physiology, and most of all, this was based on philosophical qualities, and not measurable parameters, which makes it very difficult to judge if it's good or bad. Then we come across traditional Chinese medicine, which developed around the same time as Ayurveda. This was rooted in the Taoist philosophy, systemized in the Yellow Emperor's classic. So what the understanding was basically is body was understood as a network of energy flows, which were divided into 12 meridians in a yin-yang balance, and organs were grouped by functional energetic pairs, not anatomical organs, as you can see here. Really beautiful stuff, but I wonder if it's clinically relevant. So the major contributions that Chinese medicine had were acupuncture, pulse diagnosis, though this is not used in modern physiological terms, herbal medication like ginseng, astragalus, ephedra, and which are some of which are precursors for modern drugs, and holistic conceptualization of illness. For example, like these parts over your wrist were, for example, thought to be connected with your heart, for example, if it was in your left hand, and with your lung and your chest. And similarly, this is like a detailed diagram of the meridians that were discussed. Now the problem is there are still limitations, as is with things from the past. I won't say that today we don't have limitations. Even today we have limitations, but I think today modern science is more and more moving towards the understanding that we can be wrong, which we will talk about later, because that is going to be a very interesting part in evidence-based medicine. So the limitations, what were the limitations? These energy meridians which were discussed were never anatomically demonstrated. So you can talk about all these meridians being here, but are they really there? We don't know. We can't demonstrate them. The mechanisms were often metaphorical. That is, they were not meant to be taken literally. They were meant to be taken as a metaphor. And there was no germ theory even now, and there was no pathophysiology. This chart is about acupuncture from Huan dynasty, and this image is from the expression of the 14 meridians. I'm not reading the name. I'm sorry. I'm difficult. Like, the names are difficult for me. But just appreciate the beauty of this diagram and we'll move on. So now we come to Greek medicine. This is the title page of Marco Aurelio Severio. And the snake you will see in here is something that you will often see over here in even today's demonstration and in logos and like signs and signals that signify medicine. The snakes here symbolize rejuvenation and healing to many ancient Mediterranean cultures, and in this space the single snake staff of Asilphus and the double snake staff of Claudius appear with other ancient medical images involving snakes. So snakes had a role. Why? Must be an interesting dive. We will talk about it later because we just have to get through this. This is interesting stuff, but I would want you to pursue like a lot of your interest on your own as well. So we come to Hippocrates. So this guy was known to be the father of rational medicine. He rejected superstition, viewed disease as a natural process and not as a divine punishment. He introduced systematic observation and prognosis. The core method was to observe everything, study the patient more than the disease, and the reasoning was empirical based recognition. Now, he developed this theory called the Hippocratic theory, wherein previously people would believe that if someone falls sick, it's basically oh, God has punished me. But the Hippocratic theory shifted that towards being from supernatural to being natural. That explanations there are natural explanations towards illnesses, which may be due to imbalances, environment, and habits, and are not necessarily due to punishments by God. And the observation about the supervision was that you need to listen to the patient and watch the body. He was one of the first people to systematically record symptoms. If you go back and you read a lot of descriptions of symptoms on Wikipedia and stuff, you'll find that the earliest ones we have is from Hippocrates and people from that era. It's crazy. Yeah, Danish, it's crazy. Old people have written old things. So wonderful, lovely. So detailed case notes, as I said, he was one of the first people to do that, and he put a lot of emphasis on pattern recognition. And this is the earliest version of what we call clinical reasoning. So the main idea was look, listen, and reason, and not invoke the gods because they are busy. The Hippocratic Oath. This is the part over here is a fragment of the oath from the 3rd century papyrus. So beautiful that we still have it going on, even in my medical school when I was graduating, they had us read this through. Of course, a modified version. So the Hippocratic Oath, I will not read it through, because it will take a lot of time, is a patient first confidentiality and non-maleficence based dialogue where, you want to do what is the best for patient while making sure that you don't harm them, and that is done in the confidentiality. So we come towards this fellow. His name is Galen. So this is a physician who dominated medicine for 1500 years. It's just really, it's just crazy, because from the time of Galen to the next 1500 years, a lot of the principles that he worked towards were accepted as, being divine. People never questioned it, That kind of authority is very difficult to get these days because, you might discover one thing and the next day, it turns out that, no, you were wrong. So Galen, pictured here, no, not pictured, painted over here, he was a Greek physician in Rome, and he treated gladiators. So because of this, he was able to learn anatomy from the battlefield wounds. Now, the thing is that some of the anatomy came from here, but a lot of his anatomy came from experiments on animals, which led to a lot of errors. As I said, the human dissection was looked down upon in many cultures, that so much so that it was forbidden. So what Galen could do was the best that he could. That is, he dissected monkeys, pigs, and cows. This caused a lot of anatomical errors. For example, he thought that the jawbone had 2 pieces. He believed that the liver had 5 lobes. He claimed that blood sloshed back and forth instead of circulating. And he wasn't but important news, guys, he wasn't wrong by stupidity, only by the lack of access to humans, right? Now we move on towards Unani medicine. Unani is the word for Greek stuff. Yunan was a word to the Greek Roman Empire, previously. Even in a lot of languages these days, it's still used. So we are going to talk about the Greco-Arabic bridge. The term Unani means Greek. Good job, Danish, for putting this in here. Unani traces to Hippocrates and Galen, but it was refined and systemized by Arab and Persian physicians who preserved Greek text and expanded on them. On this picture, you can see Hippocrates and Galen. And this is a painting in the fresco in the crypt of St. Mary Cathedral in Italy in the 13th century. Two beautiful young fellows just chilling out, making medicine happen. The modern Indian Unani medicine system is largely inspired by Ibn Sina, who is referred to as Avicenna in the due to the Latinization of the word. He was the author of the Canon of Medicine. So this was basically what you could call the Harrison of its time. So this was a 5-volume encyclopedia that was the medical textbook in Europe and Asia for 600 plus years. Here are 2 copies. Let me show you the copies. So here it's in Arabic, and here it's in translation, and here's our guy. So legend says that Avicenna wrote the canon in his early 20s while working nights as a physician and days as a royal scholar. He apparently said, quote unquote, "Medicine is not for those who cannot reason. The patient's story is my greatest teacher." Now, remember we started with something called the humoral theory. We'll get back to that. So the first grand unified theory of disease, which was, contributed towards by Hippocrates and Galen, was this theory, humoral theory. For almost 2000 years, medicine revolved around 4 humors. And the thing is, the Hellenistic origin of Unani medicine is still visible in its being based on the classical 4 humors like phlegm, blood, yellow bile, and black bile. So phlegm, balgam, and blood, dam, yellow bile, safra, and black bile, sauda. So here is a beautiful image encapsulating that. Now, what disease was thought to be was an imbalance of these tumors. These humors. I'm sorry, guys. It's just that it's like 2:30 in the morning, so I'm doing my best to make sure that I get this through clearly. But yeah, so disease was thought to be an imbalance of these humors. Why this mattered, even though it was wrong, was it pushed doctors to observe patterns like hot and cold, dry and wet, flushed and pale. It introduced the idea of internal physiology even without microscopes. It promoted systematic recordings of signs and symptoms, and humoral theory failed scientifically, but it succeeded cognitively. It created the first attempt at unified reasoning. Now, we'll go a little bit more into the future. So there was this theory called the miasma theory, which was basically during this era called the bad air era, from Middle Ages to the 19th century. As cities grew, epidemics worsened and people needed an explanation, and that explanation came out to be miasma, which was bad air, that is toxic vapors which arise from filth and decay. Doctors believed that diseases like plague, cholera and malaria spread through airborne poison and not organisms, which was reasonable for its time. But one of the cooler things you will see is this fellow over here with a mask, the crow mask. So this is an example of a plague doctor. And the plague doctors wore the crow masks because of the miasma theory. The long beak was stuffed with herbs, flowers, or vinegar-soaked sponges to filter out bad air, which people believe carried the plague. That is why they wore the masks. While this was still a leap forward, it linked disease to environment and public health. It resulted in sanitation, sewage, and urban reforms that saved millions. It pushed doctors to think in terms of epidemiology, not just individuals. Health is shaped by where you live and not just who you are, which was an incredibly beautiful thing, because then the next part of the video I'll show you I want you to do a home task if you have the time and energy for it. So your home task is going to be, look at this beautiful gentleman over here and look at this map. So this was a spot map of deaths from cholera in the Golden Square area. If you guess the name of this gentleman, you get 10 points, and if you're able to read on this and get back to me about what this condition is. I mean, I already told you it's cholera, but how this condition spreads and what was the entire ordeal about this, it would be lovely. And the second home task that I have for you is this lady over here. Her name was Typhoid Mary. So why is this lady, Mary Malton, called as Typhoid Mary? So that's a home task for you. Now, we move towards another interesting aspect of alternative medicine, which is homeopathy. It was basically formulated in the 1796 AD by Samuel Hahnemann, and this was supposed to be a medicine built on empathy and experimentation. And here is Samuel. The origin story is really interesting because it was based on an experiment on the Sinhona bark. So this is the diagram that I could find, which looked appealing enough to put in the presentation. So what Hahnemann did, he took these leaves, which were in fact a source of quinine, which later on was used to derive medication for malaria. And when he took these leaves, he developed malaria-like symptoms. So his ideology was, at the time, he hypothesized that like cures like. And because of this, what happened was he in fact ended up making a wrong assumption, because problem is that quinine can cause synonism, which is a syndrome with feverish feelings, headache, tetanus, oh my god, that's tinnitus, I'm sorry, nausea and malaise. These effects overlap with malaria symptoms, so though they are not identical. So imagine, you're like this old guy in the 18th century, and you take this medication which is supposed to cure you of a condition, and you start feeling like you have the condition when you take the medication. So that's where he got his ideas from. But one good thing was, he was one of the earliest to demand that doctors test drugs on themselves before using them on patients, which was a primitive precursor to the clinical pharmacology aspect of medicine that we have these days. So his core beliefs were that like cures like. One crazy thing was, he believed that extreme dilutations would cause the medication to become more potent. That is, potentization of the medication, and that the state of disease in a person was due to disturbance in the vital force. The reason that this became popular was, in the 18th to 19th century, most of the guys out there were doing crazy medicine, which included bloodletting, purgatives, toxic metals, and there was no idea of asepsis or no idea of anesthesia. How homeopathy comes into this was, it was gentle, it caused fewer harms, and it seemed beneficial. But scientific limitations to this was that the dilatations which were done were beyond Avogadro's limit. That is, no molecules remain. So there is no active molecules remaining, there is no measurable mechanism, and there was no reproducible clinical effect beyond placebo. What is placebo? Placebo is a fake treatment that can make someone better simply because they expect it to better. For example, we have these two little gentlemen over here, and Mr. Doctor is giving this thing to his patient. He's saying, this will make you feel better, and this thing could be, the medication that he's giving could be real or fake, and the patient takes it, and the patient is like, I feel better already. And this is because he believes that it will make him feel better. So in fact, since starting, all the medical practices that we've been talking about have more or less been part of alternative medicine. So for example, we touched bases on Ayurveda, naturopathy, homeopathy, and Unani. We have not touched on this osteopathic medicine, but we'll get to that, and all the stuff. So this is another image just talking about how, given a placebo, patient expects benefits, and because of this, there is a release of endorphins or dopamines, which cause pain relief. Let's talk about now that we have read and understood different types of alternative medicine. Can alternative medicine be dangerous? So alternative medicine is not clinically proven, but some choose it over conventional medical treatment. For example, cancer patients that use alternative medicine in favor of conventional medicine are less likely to survive, as per this graph. So you should try to have your patient understand that the medicine that they are trying to approach in their way of getting to be healthy is in fact causing them more struggle. Now, this is some this is an idea for people who might be familiar with the U.S. Education system. So there are two things. There is something called the MD that everyone is familiar with, and there is something called the DO, which is the Doctor of Osteopathic Medicine. Now the thing is, these DOs basically used to practice a holistic approach towards medicine, where they treat the patient as a whole and not just a symptom. And the thing is, they additionally take like 300 to 500 extra classes than a normal doctor and stuff. But these days, it's almost that both of them, both of the degrees, right, MD and DO, are almost equivalent. So you don't have to worry about visiting a DO or MD. But that's where they originated from. So this beautiful gentleman over here is Vesalius. This is the surgeon who dared to correct Galen. Andres Vesalius was a young anatomist in the Renaissance who was tired of teaching from Galen's books, so he began dissecting executed criminals, a bold and borderline illegal move. As you can see him doing this beautifully on this cadaver over here. In 1543, Vesalius published the De Humani Corporis Fabrica, with precise drawings showing Galen's errors. This was medical heresy, and he was publicly attacked by traditionalists. But Vesalius simply said, "I trust the human body more than the ancient books." So this is one of the pages from his book. From this, we get to understand that we are approaching an era of the mechanistic understanding of medicine, where we are going from Renaissance to Enlightenment. After centuries of dogma, Renaissance revived anatomy and experimentation. For example, the thinker Vesalius contributed towards correcting Galen's anatomical errors, and his influence was that observation must replace authority. William Harvey discovered circulation of blood, and based on that, physiology was gained a massive point about thinking about dynamic systems. René Descartes said body as a machine, and this led to a mechanistic model of disease. And then we have Thomas Sydenham, who was the English Hippocrates. He classified all of diseases in a way which basically become pattern-based disease taxonomy. You might have probably heard about René Descartes. He said something along the lines of cogito ergo sum, which means I think, therefore I am. I read about this on my 7th class textbook many years ago. Yeah, I'm very old, guys. And we were talking about the other guy. Sydenham was nicknamed the English Hippocrates. He was a well-respected doctor in England, and he was known for telling young doctors that you must go to the bedside. It is there alone that you can learn about the disease. He had emphasis on noting down the symptoms and making sure that a full history of the patient's health and symptoms was taken, so that correct diagnosis could be placed. He believed that disease was like plants and animals, that they could be organized into different groups. He went against the ideas of the 4 humors, which we discussed earlier, and believed that the disease was personal to the patient, depending on the stars, weather, diet. He caused progress in medicine by making detailed description of many illnesses, including the first description of scarlet fever. He also believed in allowing the body to fight the illness on its own, rather than bleeding or purging, which would have been extremely painful. This beautiful dance that you see is the Sydenham's chorea, which is also known as Saint Vitus dance, or Saint Johannes chorea, or chorea minor, or rheumatic chorea, is one of the major clinical manifestations of acute rheumatic fever, and is one of the most common forms of acquired chorea in childhood. It is a movement disorder characterized by chorea, emotional lability, and hypotonia. It is it is still a common manifestation of rheumatic fever, and one of the common symptoms that occur in rheumatic fever. So this again leads us to what is rheumatic disease, right? So you can look at this thing called the Duckett-Jones diagnostic criteria, which talks about the major parts of the syndrome, which include carditis, arthritis, subcutaneous nodules, erythema marginatum, and Sydenham's chorea, and minor criteria, which would include fever, raised ESR, CRP, arthralgia, prolonged PR interval, and previous RF. For there to be an evidence of the infection, you need 2 major or 1 major plus 2 minor of the fact. So the shift here which we observed was that observation became related to the mechanisms. Clinicians began asking how does it work rather than why does it happen. The reasoning style was anatomical and mechanistic logic. Now we go to the microscopic revolution, where we'll start by talking about germ theory. Louis Pasteur disproved spontaneous generation and proved that microbes cause fermentation. Robert Koch identified TB, cholera, and developed Koch's postulates. And John Lester brought antisepsis into surgery. So, why this change everything? Diseases now had identifiable agents and diagnosis became specific, not vague. Treatments could be targeted and not philosophical. This was the first time when doctors could say the disease that you have is caused by that organism. We're going to talk a little bit more about Louis Pasteur. He was a wonderful, wonderful person. You can see him on the right side of the screen. He came up with the germ theory, which is the foundation of modern medicine. He showed that microbes cause fermentation, spoilage, and could cause disease. He came up with pasteurization, which is heating substances to kill microbes, which revolutionized food safety. And he came up with first, one of the earliest scientifically developed vaccines, which included vaccines for rabies, anthrax, chicken cholera. What is that? I'm sorry. He introduced attenuated vaccines, proving immunity could be engineered. And next, the person that we have here is Robert Koch. He identified the exact organism behind major diseases, for example, Bacillus anthrax, which causes anthrax, Mycobacterium tuberculosis, which leads to TB, and the discovery of which led to the birth of modern modern bacteriology, which led to him winning the Nobel Prize in 1905. And he also discovered Vibrio cholera causes cholera. He developed pure culture techniques where he invented the following, which include agar plates, streaking methods, isolated colonies, and solid media growth. He also invented different staining methods, including the TB stain, which you can see in here, which is so beautifully. No, I'm sorry. It's a different. The image here is about anthrax. I'm sorry, guys, but he did invent staining methods, including the TB stain using methylene blue and later Ziegler-Nielsen variants, which made bacteria visible. He also had this huge contribution called the Koch's postulates, which were the gold standard of causation. Here, the idea was that microbes are found in every case. They are isolated in pure culture. They cause same disease when introduced into a host and re-isolated from the experimental host. If they fulfill all of these criteria, then they are an individual organism, specific organism. Now, we'll talk about how diseases start in cells, Virchow and cellular pathology. So here is one of the images from R. Virchow's lecture called Cellular Pathology from 1860s. Rudolf Virchow shifted thinking from whole organs to microscopic units. His idea was omnis cellula e cellula, which means all cells arise from other cells. That is, disease is a cell level injury, not bad humors or bad air. He connected pathology with clinical symptoms. He laid the foundation of modern reasoning, including inflammation, degeneration, neoplasia. He advocated for social medicine, arguing that poverty causes diseases. Now we get to the pathological era. This era revolutionized medicine, that disease was localized to tissues and cells. The major shifts in here were by Giovanni Morgani, who linked symptoms to post-mortem anatomy. Clinico-pathological correlation begins, Laennec, who invented stethoscope, and by his observations that clinical signs can be linked to internal lesions, and Rudolf saw that all diseases start in the cellular pathology. The impact, there was a shift from functional to structural reasoning, and bedside medicine plus autopsy correlation led to diagnostic precision. Now, we'll talk about the physiology and birth of systems thinking. This is where medicine stops being descriptive and becomes mechanistic. Here we have the following people to thank, including Claude Bernard, who came up with internal milieu, who came up with the idea of homeostasis, with Harvey, which we earlier talked about, who came up with circulation of blood in 1628, and Sherrington, who talked about reflex arcs and neurology, and then Pavlov, who gave us the concepts of physiological conditioning. In 1628, after 10 years of painstaking solitary research, Harvey at last published his discovery in a book known as Demotocordus. His idea that blood is pumped around the body by the heart in a state of ceaseless motion proved highly controversial to some, challenging the 1500 years of established scientific and medical belief. His research revealed that the blood was not concocted in the liver but circulated from the heart. In doing so, he changed the conception of physiology and life itself forever. Here we have Mr. Harvey, and this is some of the diagrams demonstrating what he came up with. Talking about Claude Bernard, he talked about the constancy of the internal environment in a way that it is the condition for free and independent life. The mechanism that makes it possible is that which assured the maintenance with the internal environment of all the conditions necessary for the life of the elements. Then we have Mr. Pavlov. He looks very happy. He came up with the ideas of classical conditioning theory, and this is basically how you can condition an organism or a physiological pathway to behave in a certain way so that you get from point A to point B. Now, what changed from this? Organs were now understood through function, not superstition. Medicine moved from what you see to how systems behave. Diagnoses became integrated, like respiratory, cardiovascular, neuro, and endocrine. Now we come to the Oslerian evolution, which starts from the late 19th century to the early 20th century. Sir William Osler was the mind of the modern medicine. He integrated bedside observation with scientific investigation. He emphasized history-taking and physical examination as diagnostic art. He promoted clinical teaching at the patient's bedside. His philosophy was medicine is learned by the bedside and not in the classroom. His reasoning style was integrative thinking, that is humanistic and empirical. The clinical loop that we talk about when we talk about Oslerian philosophy is to observe, to hypothesize, to examine, to correlate, and to reflect. Medicine was a moral science which was built on reasoning and compassion. The clinical instruments. So guys, now we are going to talk about clinical instruments and how they came to be and why you use them the way that you do today. The stethoscope. Stethoscope was one of the first diagnostic imaging devices out there. The origin story was that in 1816, René Laennec was a shy French physician who was uncomfortable pressing his ear on a young woman's chest to listen to the heart. So what he did, he rolled up a paper tube, placed it on her heart, and heard the heart more clearly than ever before. This became the monocular wooden stethoscope. Why this matters? It matters because it turned the subjective listening that I think I hear into an objective measurable value like auscultation. This signals the reasoning of modern diagnostic methods. So these are the drawings of the stethoscope that Mr. René came up with, and these are some of the drawings of the lungs. The techniques that it shaped include auscultation of heart sounds, where we can hear now murmurs and gallops, of lung sounds, where we can hear crackles, wheeze, and stridor, and of the bowel sounds, where we can differentiate between obstruction and ileus. So there are 5 areas to listen to the heart, and you can use this mnemonic. All people enjoy Time magazine. So first you have aortic region, where you put your the bell. I forgot the term. Where you put your stethoscope on top of the right second intercostal space. Then you have the pulmonic region, where you put which is located near the left second intercostal space. Then you have the Erb's point, which is at the left third intercostal space. And then you have the tricuspid, which is at the left lower left sternal border at the fifth intercostal space. And then you have the mitral spot, which is at the left fifth intercostal space, medial to the multiclavicular line, midclavicular line. So this is another diagram: aortic, pulmonary, Erb's point, tricuspid, and mitral. And these are basically the locations that you will best hear the heart sounds at. And there are murmurs involved with each location. For example, if you talk about systolic murmurs, you can look at aortic stenosis, aortic valve sclerosis, and flow murmur. Similarly, you have various types of murmurs. I think it would be better if we go into it the next time we are actually discussing murmurs, because there is a lot. So here we have the reflex hammer, which is neurology in a stick, as can be seen demonstrated here. In the late 19th century, neurologists needed a simple tool to test spinal cord integrity. John Hoffman, William Gowers, and John Taylor popularized different hammer designs. Reflex hammers evolved along with our understanding of myotatic reflex arcs. Why this matters is that it translated spinal neurophysiology into a quick bedside test and helped us understand upper motor neuron versus lower motor neuron patterns within seconds. Techniques and the uses it shaped. For example, the knee jerk led to understanding of the L2 to L4 nerves. Ankle jerk with S1, biceps with C5, C6, and triceps with C7. The ophthalmoscope, seeing the only place where you can directly see the blood vessels. So the origin story goes like this. In 1851, Hermann von Helmholtz invented it. Before this, the inside of the eye was a mystery. Here is a portrait of the guy. The reason that it matters is it unlocks the non-invasive view of the retina, optic disc, vasculature. It was the first instrument that allowed real-time visualization of systemic disease. And this is an image of an ophthalmoscope. For example, you could see something like this viewing through the ophthalmoscope, where you have a vein, you have the optic nerve, you have an artery, you have the macula, and you have the fovea. The techniques that it shaped include diagnosis of papilledema, diabetic retinopathy, the hypertensive changes, and assessing optic nerve for raised ICP, intracranial pressure, that is. So, for example, here the above image is an early phase, is in the early phase of papilledema, and this is the acute phase. Here we have some other images talking about other findings. For example, in hypertensive disease, and then vasoconstrictive phase of the disease, and yeah, we'll move on. I don't understand why the video, like the image, is scrolling up and down. It's just, in this image we see glaucoma, and compared to the normal optic nerve, compared to the papilledema. And here you can see the difference between the pressures of inside the eye and outside the eye. Now we have the otoscope, which is the window to ENT. And here is an otoscope, and here is the otoscope placed inside. The origin story of the otoscope is that it evolved from an early specula which was used in the ancient Rome. The modern designs were shaped by Wilhelm Kramer in the 19th century, and added on top of it, lightning and magnification changed the course of ENT forever. Key purposes were to inspect the tympanic membrane, to diagnose otitis media, to remove wax, and to detect perforations. In this image, you can see the tympanic membrane, the posterior fold, the anterior fold, the cone of light, and all the other features that you will see on a normal image. And similarly, you have the right ear and the left ear. And here you have, on the left side, you have a view of the normal tympanic membrane, and on the right side you have a view which changes consistent of the with otitis media. You can see there is bulging of the membrane, and there is prominent dilated vessels. Now you have a picture of the left central left tympanic membrane perforation, as you can see over here. And that is it with our ENT stuff. We are going to look at the spiganomanometer, which revolutionized how we measure blood. Well, it was firstly how it was the first tool that we used to measure blood. The interesting story is quite interesting. That is, in 1896, Mr. Riva created the first inflatable cuff, and in 1905, Korotkov identified the Korotkov sounds, which are the systolic and diastolic values which are heard while measuring the blood pressure. Why does this matter? This mattered because it turned BP from guesswork into a measurable vital sign. This enabled diagnosis of hypertension, and which ended up changing the cardiovascular mortality rates. So in this image you can see basically how the cuff is placed on the arm, and with the pressure being allowed in, as the pressure is like slowly released, the first sound that you hear is going to be the systolic one, and the last sound that you hear is going to be the diastolic one. So these days we have other types of blood pressure measuring instrument, like electronic digital spigometer, a manual mercury one, and an aneroid one. So this table talks about comparison of the American and European definitions of hypertension. Generally we can think that to be more than 130 by 80, and for Europeans 140 by 90. And there is going to be a lot of differences in the management, but we'll discuss about this when we get to a part of discussing hypertension. Well, this is like an image, as you can see, based on the readings. If we are able to get a proper reading that okay, the person is hypertensive, based on the age, we'll think about what medications that we want to start, and the ethnicity. And there is a lot of stuff in here. But I would like to proceed forwards, because I would like to get done with this, because there is just so much stuff that we need to cover today. Then we have the thermometer, which was the first objective vital sign. The origin of the thermometer was that Santoro was first attempted quantifying temperature, and in 1714 Daniel Fahrenheit, yes, that Fahrenheit, made a reliable mercury thermometer. Later on we had digital thermometers, and which led to there being infrared tympanic thermometers. Now we get to the tuning fork, which is the neurologist and the ENT specialist's secret weapon. The origin of this tool was that it was invented by John Shore in 1711 for tuning musical instruments. Later on, it was repurposed for medical use centuries later. So the uses that we have are at 128 hertz. We can use it to check for vibration sense, and at 512 Hz to check for air versus bone conduction in ENT with Rene test and Weber test, which are demonstrated over here. On Rene test, you place it like this. On Weber's test, you place it over the head. I would love to get into the detail, but let's just move on. Now, talking about the ECG machine, from frog legs to cardiology. The origin of the ECG machine was that in 1940s, Emil Debo noticed that there was electrical activity in the muscles. In 1870s, dogs and frogs were said to have cardiac impulse recorded, and in 1901, William Antoine invented the string galvanometer, which was the first ECG. So this is our guy, and this is like an illustration which demonstrates that there is nervous transmission of a chemical nature. And this is one of the first ECG machines in history. The clinical impact was that there was sudden transformation of cardiology. We could look at things like myocardial infarction, arrhythmias, and electrolyte imbalances, electrolyte disturbances. Okay, let's take a little small break of 2 minutes and then I'll get back. Hello guys, so back to our work. The technology century in the 1900s. Once physiology matured, technology transformed medicine forever. Here we have a really lovely story happening. So this was one of the first X-rays ever taken, and our guy, Mr. Doctor, was he a doctor? I don't know, but we will check. We will see through things. Rottingen, in 1895 came up with the concepts of X-rays. That is, you could see inside of things without cutting them. Previously we talked about how ECG was developed and how it helped us to have an understanding of the electrical view of the heart, and then you have CT, MRI, and ultrasound, which help us get a structural and functional imaging of the structures that of the organs and organ systems that we're working with. In 1950s and 60s, we came up with the ideas of ventilators and ICUs, which helped us manage physiology in real time. This transformed medicine in the or falsify hypothesis using machines. Before, reasoning led to crude observations. Now, reasoning leads to observation plus data plus images. Let's first talk about X-rays. So the X-ray helps you see the invisible. Here is a beautiful X-ray of the neck. The story behind the discovery of X-rays is really fascinating. Wilhelm Conrad Röntgen, Röntgen is how his name is pronounced, I hope, I think so, was a German physicist who was experimenting with cathode rays. He noticed that a fluorescent glow on a screen across the room despite solid objects being in between. This way he realized that a new form of radiation was passing through the surface, and he did not know what those rays were, so he called them X-rays. X stands for a name holder, meaning unknown. The first medical X-ray that was ever taken was of his aunt's wife. Her bones plus the wedding ring being visible. Let me show it to you. Look at this. How pretty is that? So why was it invented or discovered? Initially, it was an accidental discovery, but quickly adapted to medicine because it penetrates soft tissues and allows the bones to be seen very clearly. And for us to be able to see foreign bodies, fractures, and lung changes. The problem it solved was that before X-rays, bone fractures were pure guesswork. Now, chest diseases, including sorry, before X-rays, bone fractures were pure guesswork, along with chest diseases like TB, pneumonia, which were also speculative. And with the advent of X-rays, we are able to just see through and not have to guess through or speculate about what is happening. How do X-rays work? In a simple manner, how they work is high energy photons pass through the body. Dense tissues like bones absorb more, so they appear white, and air absorbs least, so it appears black. Here is an image showing the X-ray production. You have your cathode over here, you have your anode over here, and this is how this works. Another beautiful image. We have the X-ray machine over here. The X-ray beams are being produced, and then they fall onto a surface on the other side, and you get your X-ray. Modern uses for X-ray are use X-rays to look at fractures, pneumonia, TB, pleural effusion, and bowel obstruction. Oh, CT scans. CT scans allowed us to have 3D anatomy for the first time. The inventors were two people, Sir Godfrey Hounsfield, whose name is used as the measuring unit, in fact, and Alan Cormack, who was a physicist. Both of them won a Nobel Prize for this discovery. Why was CT scan invented? The problem was that X-rays were 2D, and because of that, overlapping structures were difficult to interpret. Doctors needed cross-sectional imaging to identify the following, such as brain lesions, tumors, hemorrhages, and organ injuries. The problem that it solved was, before CT, diagnosing stroke versus hemorrhage required invasive carotid puncture imaging. CTs provided rapid, non-invasive brain imaging, and they're great for bone, blood, and acute injuries. How it basically works is, you have a X-ray on the other end, but this time the X-ray is a rotating tube, and there are detectors around to create multiple slices. The computer then reconstructs them into cross sections, so that you have a 3D rendition of the image that you're trying to make, which looks something like this. This is a simplified model of a CT machine. Talking about the MRI, imaging without radiation, the donut. Yes, you're on Dr. Donut, so I had to say that. The discovery of MRI was based on nuclear magnetic resonance physics. It was invented by Paul and Peter Mansfield, and they were awarded the Nobel Prize in 2003 for their discovery. Why was the MRI invented? We previously had CT, and CT was good for bone and blood, but was not so good for soft tissues, ligaments, tendons, spine, and brain white matter tracts. What MRI solved was, it provided superior soft tissue contrast without radiation. It revolutionized brain, spine, and musculoskeletal imaging. How it basically works is, the magnetic fields align hydrogen atoms, and then radio frequency pulses disturb them. The way that these hydrogen atoms return to their alignment creates the MRI image. For example, as seen in this image, firstly you have protons in a particular direction, and then you turn on the magnetic field, and then they're aligned. Once the magnetic field is off, they go back to their normal state, and that is how you get to have your beautiful MRI scans. Here is another image explaining the same. So MRIs work really well for brain tumors, musculoskeletal system, ligament tear, disc prolapse, and soft tissue tumors. As they provide no radiation, they're relatively safer, but not so cost effective. And they also provide multiplanar imaging in sagittal, coronal, and axial axis. Now we come to ultrasound, which is made in 1950, which is like worked on in 1950s and 60s, which led to real-time imaging. Now, the origin was that it was inspired by the sonar technology which was used in submarines in the Second World War. Medical pioneers like Ian Donald applied it to obstetrics. The reason that it was invented was radiation, as we understand, is very problematic for pregnant women, right? So we needed a safe non-radiation method to visualize pregnancy, abdomen, and pelvis. The way that this works is we have high frequency sound waves which we send, and then they are reflected back to us, and we detect them using a detector, and this is how the image is created. For example, we use elements like piezoelectric crystals which emit these waves, and they fall into the organ, they are reflected, and then we detect them and we get the image. The strengths that ultrasound have includes the following. That is, an ultrasound machine is portable. You get your scans in real time. There is no radiation involved, and it is great for OBGYN, for gallstones, for kidney stones, and for fast exam in trauma. Let's move on and talk about about PET scans, which helped us understand that we can image metabolism and not only anatomy. The origin of PET scan is primarily from nuclear physics research, wherein it was later combined with CT, which led to PET CT. Why was it invented? It was invented because CT MRI shows structure, but PET scans show function and metabolism. The way that it works is basically you have a radio-labeled glucose taken up by active cells, and what happens is that there are cells which are involved in causing diseases like tumor cells, infectious cells, and inflammatory cells. These take up more glucose as they are active cells, and because of them taking up more of this radio-labeled glucose, we can detect them and see where they are present, as can be seen, for example, in this image where we are injecting the patient, and then we are sending it through computer for processing, and we get our beautiful PET scans. The strengths of the PET scan include that they help us have a really good understanding of oncological staging. They help us understand occult metastasis, and they help us understand cardiac viability and neurological disorders. Now we're just going to have like an overview of the different modalities that we discussed, and what they're good for and what they're bad for. Not bad for, but their weaknesses. So talking about the first modality, we have X-rays, which were invented in 1895. They help us see bones and chest, and their strengths are they're fast and cheap, but the thing is it's just 2D at the end of the day. Then we have CT scans, which were invented in 1971, which primarily help us see cross sections, and they are really good with bone, blood, and trauma. But the thing is, because there are multiple X-rays being taken at the same time, the patient is exposed to a lot of radiation, so that's bad. Then we have MRI, which was invented in 1980s, which was primarily for soft tissues including brain, spine, and joints. But the thing is, it's expensive and quite slow. And then we have ultrasound, which is a safe real-time option for OBGYN and abdomen scans. But the thing is, it is very operator dependent. That is, the person that makes the scan determines if the scan is going to be good or not. Then we have the PET scan, which primarily talks about metabolism and helps in oncological staging. But the thing is, as we talked about this earlier, PET plus CT, this is both costly and has a lot of radiation issues. Then we have this beautiful technology called fluoroscopy, which is which basically provides you real-time movement, real-time x-rays, and it is used in a lot of procedures. But the problem is it has the highest radiation. And then we have something called mammography, which is primarily for breast cancer, for the screening of it. But the weaknesses that this technology has is there is pain involved and radiation. We'll take a break for 2 minutes. Hello there, guys. Now we are going to talk about evidence-based medicine era, the one that we have been building up to until this point. It began in the late 20th century with David Sackett and McMaster Group, who founded evidence-based medicine (EBM) in the 1990s. The core idea is that clinical decisions must rest on the best available evidence. And this introduced hierarchies of evidence, like randomized control trials, which hold the highest importance, and then cohorts, then case studies, and then expert opinion, which we will of course talk about more. So what is evidence-based medicine? That decisions be based on measurable outcomes, not just expert opinions, and that doctors must justify their choices with evidence plus logic, not authority. Now, I feel like my computer is getting slow. The reasoning style is probabilistic and data driven. That is, you can't say, I think this works. You have to say, it works because the evidence shows that it works. So here we have integration of research, clinical expertise plus patient values. So what is a modern clinician? Who is a modern clinician? A modern clinician is a data scientist and an empathetic humanist. As we can see in this image, there are multiple levels of evidence. The topmost you have is clinical practice guidelines, which are released by organizations, and they basically make these guidelines based on meta-analysis of systemic reviews. And these meta-analysis are based on multiple randomized controlled trials, which are the golden standard for trials, right? And these take data, a lot of the times these are built on top of cohort studies, and then on the next level of evidence we have case control studies, and then we have case reports or case series, which include some of the least informative options that we have, and only then we get to expert opinions. And if we don't have any of that, then we get to animal and laboratory studies. Beautiful transition. It's so fast. My computer is so cool. The cognitive era. Now we are talking about the cognitive era, which is from 21st century to present. Medicine now recognizes that diagnostic errors are often due to cognitive biases and not ignorance. That Pat Crosscarry and others introduced cognitive biases model in diagnosis. This led to rise of reflective practices, metacognition, and dual process theory. System 1 and System 2. This is interesting stuff, and we'll get into it. Incorporation of AI and machine learning as cognitive extensions and not replacement. Emergence of narrative medicine and shared decision making. Just a moment. Can I make this a little faster? Oh shit. Oh shoot, sorry. I shouldn't swear. How do I? Okay. Happens with the best of us, guys. I'm not the most well versed with these things. It's just that I thought if I turned off the extensions, my computer would be a little faster. Just give me a second. I'll be there. Don't block pop-ups, bro. We need pop-ups. Done. Allow this pop-ups. Okay. Yeah. Beautiful. I am so sorry for the little disturbance that we had, but we can continue now. Can we continue? We should be able to. Wait a second. Just give me 1 second. Okay. So yeah, I am so sorry for the delay. This is like sometimes things like these happen. It's all right. So we were talking about the emergence of narrative practice and shared decision making. The current model that we have is evidence plus empathy plus epistemic humility. That is, we reason with data and not through it alone. That is, we must justify our choices with evidence plus logic and not authority. Epistemic is an adjective. The word is an adjective, which means of or relating to knowledge or the conditions for acquiring it. Now, we have some understanding of the entire model. So we'll just try to think about how clinical reasoning has come to be. At first, we have, as we discussed in the previous videos and previous parts, the ancient era where the dominant model was observation. The core question was, what patterns do I see? And the modern legacy from that is the clinical eye. Then we have Renaissance, which talked about mechanistic era, where we asked how does this thing work, which helped us get to the physiological logic. Then we had the pathological era, where we were talking about the anatomy of stuff, that is, where is the lesion located, which helped us localize things. And then we have the Oslerian period, where we had integrative model, where we talked about what does this patient of it in the bedside reasoning. Then we have evidence-based medicine, which is the analytical part, which talks about what does this data say, which led to critical appraisal. Now we are in this part about cognition, that is kind of metacognition, where we are reflective about how do I think. We have metacognition. So how do we go about it? We have to start with the following things. Today's physician uses the following things, including clinical reasoning, pattern recognition, imaging, labs, physiological principles, decision rules, risk scores, and Bayesian thinking. I don't know how to pronounce that word. That's the problem, guys. When you read a lot and you don't talk about things to people, it happens. So you start with the following. First, you observe what is happening, then you analyze, then you predict, and then you act on this prediction, and then you reassess. So, but what is the Bayesian thinking? That is, you update your beliefs with new evidence. That is, you start with hypothesis, you gather evidence, and then once something happens, once you get a new evidence, you're like, okay, I changed, I'm better now. The idea is basically, once you get evidence, you you test whether it fits your understanding or not, and if it doesn't, you update your understanding, right? So what I want you to understand is that you as a person are the heir, you are the heirs to the centuries of cognitive refinement which happened in the past centuries, and you must own that lineage. It's a beautiful thing. So many people worked for this, and now we take the mantle forwards and we walk with it. So, the modern day clinician's triad. Today's clinician must have the following things. The following balance, right? So, there are 3 domains that a physician must have, which include science, that is why what is happening biologically speaking, and it helps understand the pathophysiology and the diagnostics. Then we need to have logic, that is what is the most probable cause, what is the most probable thing, which involves evidence-based medicine, statistics, and probability. Then we have humanity, the part about humanity which talks about what matters to the patient. Here we think about communication and ethics. So to just get a review done about this entire thing, firstly we discussed about what humors were and how and why they made sense, and then we talked about miasma, and we linked into environmental diseases, and then we talked about germ theory, about how microbes replace metaphysics, and then about Warsaw we talk about cell level understanding, and then in the physiology part we talk about systems thinking, and then in technology we talk about verification and measurement, and then in the evidence-based medicine part we talk about quantitative decision making. And now finally we came to the model clinical reasoning, where we were able to get into the integration. So guys, that is the break time. If you have any questions you can ask. I think probably I'll end this video now here, because I feel like my computer is taking too much like the CPU is taking too much load due to this presentation being like too big. So I'll just divide it into 2 parts and I'll post the second part later. But I just want to say that it's really lovely to get this opportunity to speak about things and do my presentations, my little teeny tiny presentations, and I would love any suggestions, any opinions that you guys might have regarding this or anything else. And as I said, this is going to be a 13-week series, so as we progress, I'll make more and more content, and hopefully we are able to get a really nice overview of what medicine is. So yeah, I enjoyed making this, but I was a bit anxious. Of course, if anyone who starts making big things like these is going to be. But thank you for if you have listened to the end, thank you for that, and congratulations, and see you in the next part. Bye. Oh, by the way, the week 1 has not ended yet. The next part will still talk about. We will still be talking about the other about the first week. Yeah. Bye bye.